President-elect Ramon Magsaysay in 1953 held so much promise. With his country only 7 years out of the war, Filipinos felt that he was the leader who truly represented the masses and would direct the country's growth. He was young, his energy was boundless, and his commitment to serve the people was unquestionable.
I believe that the President should set the example of a big heart, an honest mind, sound instincts, the virtue of healthy impatience, and an abiding love for the common man.
President-elect Ramon Magsaysay in 1953 held so much promise. With his country only 7 years out of the war, Filipinos felt that he was the leader who truly represented the masses and would direct the country's growth. He was young, his energy was boundless, and his commitment to serve the people was unquestionable.
I believe that the President should set the example of a big heart, an honest mind, sound instincts, the virtue of healthy impatience, and an abiding love for the common man.
Scientific pursuits, the accumulation of knowledge through experiments and data gathering, are about discovering solutions to many of the problems we face. In Bangladesh, a woman of science has been leading the charge in finding medical breakthroughs that have improved the quality of our lives. These include key roles in developing vaccines for cholera, typhoid, and E. coli diarrhea, and more recently, vaccine trials for COVID-19. She has built infrastructures and institutions that continue to spark students' interest and motivation in learning and pursuing scientific discoveries in health and medicine. Her work, however, is not limited to the laboratory. She is active in community engagement, clearly articulating specialized knowledge on vaccination to lay people in the community. She spearheaded various mass inoculations in high-risk areas such as slums and refugee camps, saving the lives of literally millions. Dr. FIRDAUSI QADRI, a Bangladeshi scientist, combined her brilliant mind with her compassionate heart to use science to inspire and ignite action for the common good. That to us is greatness of spirit.
The Ramon Magsaysay Transformative Leadership Institute online lecture series featuring 2021 Ramon Magsaysay Awardee Dr. FIRDAUSI QADRI will begin in a few minutes. We would like to remind the audience of the following. The video and audio functions of our audience will be disabled during the panel discussion. For questions, clarifications, and/or comments, we encourage everyone to use the Q&A tab and the chat room in the Zoom webinar. We will try to address as many relevant questions and comments during the session. Please be always respectful in the chat room and the Q&A tab. We invite you to visit our brand new website, www.rmaward.asia, for more information on the Ramon Magsaysay Award and this year's laureates. We invite everyone also to follow the Ramon Magsaysay Award on social media. You may find us on Facebook, Twitter, Instagram, LinkedIn, and YouTube. Thank you for joining us. We will begin the program in 2 minutes. Good afternoon and welcome to the Ramon Magsaysay Transformative Leadership Institute online lecture series featuring 2021 Ramon Magsaysay Awardee Dr. FIRDAUSI QADRI for Bangladesh. Dr. Kadri will be sharing with us her vision and experiences in creating human and physical infrastructures in research and development in Bangladesh. This goes beyond the laboratory to create meaningful impact which will benefit Bangladeshi communities and the world at large. Immediately after the lecture presentation, we will have a reaction from our invited panelists, all esteemed global health experts. After the panel discussion, we will be opening the floor to questions from our audience. You may use the various platforms on Zoom, on Facebook, and on YouTube for your questions. To formally open this day's events, please all welcome to your grid the President of the Ramon Magsaysay Award Foundation, Ms. Susan Afan.
Thank you so much, Masaki, and welcome everybody. We are welcoming you to the last chapter of the Ramon Magsaysay Transformative Leadership Institute lecture series for 2021. And I gotta tell you, friends, we're definitely in good company this afternoon. We have the pleasure of having health experts from across the world, from the Philippines to Bangladesh, to the United States, and even Switzerland as part of our panel. Led, of course, by 2021 Ramon Magsaysay Awardee, Dr. FIRDAUSI QADRI. The lecture series is the unique highlight of the Ramon Magsaysay Awards Festival. This is where the public is given actually an opportunity and access to our Ramon Magsaysay laureates, learning about the respective leadership journeys in their own words. We would like to send our deepest appreciation to members of the Ramon Magsaysay Award family who are with us today. We are also joined by two of our Board of Trustees over and above, of course, our moderator, who I will introduce shortly. But with us this afternoon as well is Mr. Ramon Del Rosario and our Chairman of the Board, Mr. Gigi Montinola. We also have members of our, part of our Magsaysay, not just our Magsaysay trustees, but a handful of our Magsaysay laureates, key partners of the foundation, and friends of the community as well. We would also like to thank our friends from Bangladesh, from ICDRB and Aideshi, both organizations founded and led by Dr. Kadri. Thank you so much for joining us. Thank you as well for taking time from all your packed schedules to join us. Moderating today's very special online lecture is a member of the Ramon Magsaysay Board of Trustees, Mr. Ernesto Garilau. Mr. Garilau is the chairman and president of the Zulig Family Foundation, whose mission is to reduce health inequities to improve health outcomes of the poor. He was actually a faculty member of the Asian Institute of Management from 1999 to 2010. He also served as secretary of the Department of Agrarian Reforms from 1992 to 1998 under the administration of the former president of the Philippines, Fidel V. Ramos, and vice chairperson of the Social Reform Council, which is the highest policy-making body of the Philippines' anti-poverty programs from 1999 to 1998. So it is my pleasure to introduce him to you. May I now turn over the Zoom session to our moderator, Mr. Ernie Garilau. Hi, Ernie.
Thank you, Susan. Thank you very much. Good afternoon from Manila, and thank you for joining today's online lecture. It is my pleasure to introduce the reason why we are here today. Dr. FIRDAUSI QADRI is an international scientist at the Center for Vaccine Sciences in International Center for Diarrheal Disease Research, Bangladesh in Dhaka. For more than 25 years, Dr. Qadri and her team have been working in collaboration with international and national organizations on intensive research related to communicable diseases, immunology, vaccine development, and clinical trials. In 2014, Dr. Qadri founded the Institute for Developing Science and Health Initiatives, which conducts biomedical research, training, and testing, making it a hub of scientific activity for local and visiting scientists in Bangladesh. Her efforts were recognized by local and international bodies. In fact, UN Secretary General Ban Ki-moon appointed Dr. Qadri and 9 members to a high-level advisory panel on the proposed UN Technology Bank aimed at helping the least developed countries overcome poverty in November 2014. In 2021, she was elected to receive Asia's Premier Prize and highest honor, the Ramon Magsaysay Award, for her passion and lifelong devotion to the scientific profession. Her vision of building the human and physical infrastructure that will benefit the coming generation of Bangladeshi scientists, women scientists in particular, and her untiring contribution to vaccine development, advanced biotechnological therapeutics, and critical research that has been saving millions of precious lives. Ladies and gentlemen, my honor to present the 2021 Ramon Magsaysay Awardee, Dr. FIRDAUSI QADRI. Good afternoon, Dr. Qadri.
Good afternoon. Thank you, Mr. Ernesto, for this honor. And
May we now request everyone to turn off their camera and mute their audio during the talk of Dr. Qadri. Let us now listen to Dr. Qadri. Dr. Qadri, you have the floor.
Magsaysay Award, which I have received and I'm very thankful for. And I would personally like to thank the Ramon Magsaysay Foundation, the family members of Ramon Magsaysay people, and of course Victor and Susan, who have worked so closely with me in helping me throughout this whole period from the time in late August that I received this prize. So I would like to tell the story of my life, and naturally, I start from the laboratory and down to the people. So I've titled this talk From the Laboratory to the People, Creating Impact on Science and Communities. And I will tell you my story. So I have been working on infectious diseases all my life, and I work at the ICDDRB, which is known in many ways as the cholera center of the world and in Bangladesh. But cholera is an ancient disease. It is still creates epidemics and outbreaks. It is an ancient disease that you see writing in the Bible and other holy books, but it continues until today. It is a disease seen in fragile populations and earthquakes, floods, man-made disasters, especially when people are displaced from one person to another, like you see in Syria, Yemen, and in Cox's Bazar, where we have people from Myanmar in Bangladesh. So if you look at Bangladesh, we have, the cases that we talk about, like 109,000 cases annually, and 1.64 incidence rate per 1,000 population. And at risk population, it is about 66 million people are at risk. Every year at the ICDDRB where I work, we see over 20,000 people coming in. Cholera comes in two major peaks, but even without peaks, you see cholera in crowded circumstances, like now in Bangladesh. So our research has been based on understanding. My research with my team at ICDDRB has been based on trying to understand natural cholera disease, which has led to understanding the burden of the disease, the immunity that the disease causes to people and protects them from further disease, the host response, and as well the host and the pathogen interactions. So Vibrio cholerae is a gram-negative bacteria belonging to the family of Vibrionaceae, highly motile organism. It's wonderful to see it under the dark field microscope, where the rapid movement of Vibrio cholerae always makes me feel very happy. Not because it causes disease, but because of the excitement with which they move. And in order to understand the disease, we've done, together with my team, nationwide cholera surveillance in Bangladesh since 2014. And not that we weren't doing it before, but we did very good, well-organized, well-planned surveillance in 22 sites in Bangladesh. And we've got insights where in Bangladesh we have cholera in the 22 sites. And it varies from 3% in one area to over 15% in some areas. And so you have see the map of Bangladesh. And in this map, we have places east, west, north, south, where the epidemic pattern is different. In Dhaka city, you have a spring peak and a after monsoon peak. In other countries, you have winter peaks or different peaks. Even it varies from east to west, north to south. So based on this, we have been thinking of many strategies for prevention of the disease. And we know that Kumilla, Chittagong, Dhaka, Cox's Bazar, Narayanganj, and the south of Bangladesh, Bakirganj, is very high in cholera. We've also looked at, our main emphasis is on Dhaka city because it's the capital of the country. We have a large urban population living in slums, almost 40% of the people, and there's a high burden of cholera based on the ICDDRB cholera data. So it's a hand-to-mouth disease. The more you live in unhealthy conditions, the more you do not have clean water to drink, you have bathrooms to share, and you cannot maintain hygienic conditions, you will have cholera. So we have also tried to understand it in the lab, to understand the disease and the vaccination efforts, and we've looked at patients with Vibrio cholerae infection, and we found that they develop robust immunity, robust immune responses. They produce antibodies, they produce T cells, Th1, Th2, CS17, they have memory T cells, they have helper T cells, and a very strong immune response, even in young children. And the magnitude of these T cell responses is also directly related to the memory B cells that come up. You understand, memory cells are very important in infection and in vaccination, because if you have memory cells, then these cells get activated every time you get exposed to a pathogen, to that same pathogen. And so for cholera, we have very good memory B cell responses and also T cell responses. We know that cholera also gives not only a non-inflammatory disease, but it produces a very strong pro-inflammatory response. And this pro-inflammatory response is seen in patients, in vaccinees. It's very good for us to have some level of pro-inflammatory response, as we have seen. We've also been able to produce monoclonal antibodies, not only in mice to cholera, but also from human cells, from patients who've had cholera disease. And we've produced monoclonal antibodies that can be used for diagnostic purposes in collaboration with Harvard Medical University, Emory University. And I'm not naming names. You can see all these brilliant people in my unit who who have been working together to understand cholera better. And we have other infections. Other infections that pose a problem for children in Bangladesh, but also for adults. I will also focus on another major enteric disease, which we are worried about all the time, and that's typhoid fever. It is caused by bacteria belonging to the family Enterobacteriaceae. It produces disease, and Salmonella typhi is the pathogen that causes typhoid fever. And we've done a lot of studies. You can see in this picture a child with undifferentiated fever with febrile illness, and you don't know whether the child has got dengue or chikungunya or kala-azar, because just fever, no other symptoms can be present. So it's very difficult to diagnose typhoid in comparison to cholera, because a person can come in with half their body weight lost in cholera. You can understand it is profuse dehydration. But with typhoid, a child can languish for 7 days at home, and nobody will understand that he has a disease that can be such a big problem. And so the source of the organism is Salmonella typhi, and you get acute typhoid fever patients and also chronic carriers. So a person who has had typhoid can carry on the pathogen in their gallbladders and in other organs, and we can keep on secreting it, and can be a big source of infection for other people in the house, in the community. And it is like cholera transmitted to food and water, and there are many complications that can arise from typhoid fever. Cholera is a non-invasive disease, that it does not get into the blood usually, but typhoid goes into the blood. It has a gut response, gut phase, and it also has a blood phase. So it can cause intestinal perforation, encephalopathy, bleeding, shock. So it can, especially in young children, it can be a major cause of problem. And also there's a lot of antimicrobial resistance in these bugs. So you get, but the best thing is that you get high antibody responses in both the mucosal and systemic immune responses in compartment, and these are stimulated in disease. And we've also seen by whole genome sequencing of Salmonella in Bangladesh using the Illumina platform that these bacteria have the non-H58 genotypes carrying fluoroquinolone resistance mutation that are actually quite dangerous. They are the MDR1 H58, and these are things that we have to worry about a lot because of the high scale at which antibiotics are being used in Bangladesh. So I'm talking about the laboratory until now, high throughput techniques, but what have we done to prevent these people from these diseases in Bangladesh? And the two examples. So together these two diseases cause over 20 million cases and at least 250,000 deaths globally. And Bangladesh has a major portion in the deaths. How are we trying to find a solution to this problem in Bangladesh? And how have we contributed from my team for elimination of typhoid and cholera? So I'm going to talk to you about this story on the field level. We are focusing both on vaccines, both which are taken by the mouth and also those that are injected. So a little bit about vaccination in cholera. So in cholera, traditionally, until the 70s and late 70s, early 80s, the vaccines that were given were injectable vaccines by parenteral route. And these vaccines gave only short-term protection, gave a lot of side reaction, side effects, and was not very immunogenic. It did not prevent anyone from cholera for a long time. Maybe for 3 months, was not very protective. But the concept of vaccination changed from the parenteral route to the oral route from early 1980s. And then the inactivated cholera toxin B subunit vaccine was developed in collaboration of ICDDRB with the Gothenburg University in Sweden. And the first trial was carried out in Bangladesh in our rural site in Matlab in 1980s. And Dukoral, the vaccine that was tested was then registered and WHO pre-qualified as Dukoral. So it is a vaccine, as you can see in the field trial in this photograph when a vaccine was, the first picture is of a parenteral vaccine which hurt a lot. The second picture is of the parenteral vaccine, oral vaccine given to people, and also the oral saline that is given to people. Then from 2000 onwards, the concept changed. The thought process began that vaccines need to become available to people, make it easily feasible for people to take, make it affordable for countries to use, and from then the development of an affordable, simple formulation cholera vaccination began. The first vaccine was Shankol, registered pre-qualified by WHO, and that was used in many of our trials in Bangladesh and many studies and campaigns all over the world. Followed by this, we used that technology, and through our innovation, through our persistence, the vaccine have been tech transferred to Bangladesh and transferred to a company. The first vaccine you see on this picture, this vaccine is the Colvax vaccine, absolutely the same as the vaccine Shankol that was first WHO pre-qualified, same as Uvicol that is produced in Korea by U Biologics, and this has been tested in Bangladesh, and we find it to be non-inferior to Shankol. And there's another vaccine, a simple vaccine made only with one strain, which also is a collaboration with Sweden and other collaborators, and we tested this in Bangladesh. It was tech transferred, formulated in a company in Bangladesh, and we tested it. And we showed that both the vaccines are non-inferior to the Shankol vaccine, which is WHO pre-qualified. So we have a step forward. We've carried out large cholera vaccination campaigns in Bangladesh from 2011 onwards. Before that, we've done many trials. So we seriously thought about doing campaigns in Bangladesh, doing studies that would bring us closer to using the vaccine in Bangladesh. So we've at least used 5 million doses to test feasibility of the oral cholera vaccine in urban slums in Dhaka city, where the hospitalized rate due to cholera is very high. We have also used about 5 million doses of the vaccine in fragile populations of Myanmar nationals who were forced into Bangladesh from August 2017. And we believe in our calculation, in a population of 170 million, we would need about 173 million doses of vaccine in the next 4 years to eliminate cholera. Based on all this, a national cholera control plan has been formulated, and we have a multi-sectorial plan, and which is to not be isolated. You use vaccines and also use other approaches for prevention of cholera. Cholera is a hand-to-mouth disease, contaminated water, food, especially water, and lack of hygiene, lack of sanitation, lack of knowledge about hygiene, and sharing of bathrooms, and all these factors lead to cholera. So a multi-sectoral plan is important to have both vaccines and WASH and surveillance together. So, and in order to test this, so we have carried out this vaccination in Cox's Bazar among the forcibly displaced Myanmar nationals and the host population in Cox's Bazar. Just to remind you, in our surveillance in 22 sites, we have found that cholera is very high, rates are very high in Cox's Bazar. So when the Myanmar nationals were forced into Bangladesh, our first thought was, how do we prevent them from cholera and cholera deaths? And that is why the WHO Global Task Force for Cholera Control sent vaccines in a matter of 7 days after request from Bangladesh. And from that time onwards, there have been 7 campaigns in Bangladesh, and some many in the FDMN population, but some in the host population, because the host population in Cox's Bazar live very close to the refugee population, and they can be at risk also. And so we have done a lot of these vaccinations. The last one was completed in November 2021, and we are waiting for more vaccines. And there was a lot of delay due to the COVID-19 pandemic, but we are now, I hope, on our way to elimination. We now have a slide to show you the National Cholera Control Plan for Bangladesh, which was approved by the government of Bangladesh in 2019. And the plan is from 2019 to 2020 to have oral cholera vaccine that will cost us about $0.43 billion. We will have a lot of effort on WASH, which will cost us about $3.13 billion. And we will have a surveillance, which will be least expensive, but still surveillance. Why? To know whether these programs are being able to eliminate cholera and reduce cholera. So we need a budget of about $4 billion to achieve all this. So the global roadmap objective is to reduce the mortality resulting from cholera by 90% by 2030. And Bangladesh is one of the 8 countries with high cholera burden that has been chosen for this elimination program. And so our short-term goal is to reduce cholera 25% by 2021, mid-term is 50% by 2025, long-term is 90% by 2030. And so we have key interventions for this from 1 to 6 that we are trying to regenerate, reactivate in spite of the COVID pandemic that we have seen. And we have first step of this activation was to carry out a campaign in Dhaka city, which was our demonstration project. Can we do it? And we did it. We used 6 thanas in Dhaka city, as you see in this table. And the 6 thanas, we had so much participation from the community. Everybody, no matter from where they came, from the urban slums or from the middle class people or rich people, they all came for vaccination. And so we finished all this by March 2020, by end of February, and we had to stop the second vaccination because these are 2-dose vaccination programs. We had, like the COVID vaccine, and we had to stop it because of the pandemic, and we were under lockdown, had problems, and we could not vaccinate, and our health system was very busy trying to curb the epidemic of COVID. So now I will talk about typhoid fever and the initiatives we have taken for introduction of vaccine for prevention. So we have had, like the cholera vaccine, different types of typhoid vaccines since 100 years. So first of all, there's the parenteral VI polysaccharide vaccine. Before that, there was the inactivated typhoid vaccine, like the parenteral vaccine you saw that I showed you for cholera. It hurt a lot, gave not that much protection, and then it was withdrawn. No, it's not used. And it did not give any protection to children less than 2 years of age, but only important for children above 2 years of age. So then there was this TY21A oral cholera vaccine, but this cannot be used below 5 years of age because children don't mount a response. Then has come the typhoid conjugate vaccine, the tetanus toxoid conjugate vaccine, VITCV, and which it is a WHO pre-qualified vaccine, only 1 dose is needed. It is immunogenic in children in all ages. It has hopefully a prolonged immunogenicity we have seen in our field sites, shown to have minimal side effects. And it gives us 85 protective effectiveness in children 9 months to 15 years of age, less than 16 years of age. And so we are very excited about this study, which has also been shown to be very good in Nepal and in other countries in Africa. So typhoid vaccine initiatives are being carried out for introduction of typhoid conjugate vaccine. So we need a protective vaccine for children. We have it now. We have disease burden data from our studies. Both community and hospital-based surveillance is available now. The community-based data has come from my team at ICDDRB in collaboration with countries, University of Oxford and so forth. The Gavi Alliance has approved $85 million to support introduction of typhoid vaccine in developing countries. The Bangladesh NITAG, in a meeting in July 2021, has recommended use of the typhoid vaccine in routine immunization and catch-up campaigns. So this is a single-dose vaccine, can be given at 9 months or can even be given at 6 months. But it can be co-administered at 9 months when the measles rubella vaccine is being given. Surveillance on disease burden needs to be continued, which we are carrying out. COVID-19, however, reduced the initiative and the speed at which we were going for the introduction plans. But we are hopeful now, when so much vaccination for COVID-19 has been achieved in Bangladesh, we have almost 40% coverage in the target groups. Our team has had many problems. My MIVU team to change course due to COVID-19 pandemic, which temporarily halted ongoing studies when the COVID pandemic started in March 2020 in Bangladesh and also shook the world. So our natural studies that we were carrying out in cholera, the surveillance programs that we were carrying out, the typhoid responses that we were studying, the genome analysis in cholera and typhoid, the preemptive vaccination that we were carrying out in Dhaka city, the many cohorts were terminated because we could not progress. And we then developed and initiated projects on COVID-19 because our team was well set, not only for study of cholera and typhoid and other enteric diseases, but also for seroprevalence, natural infection, vaccine trials, pathogen studies for COVID. And we have also done a lot. We have already published about 4 or 5 papers minimum in which we have been able to show that we have in mild disease, even in mild disease, 100% of COVID-19 patients are seropositive for IgG antibodies to the receptor binding domain, and about 45% asymptomatic also respond, but newer studies show that all asymptomatic patients also respond with antibodies. We have done a lot of studies in collaboration with our teams at ICDDRB, with the government team, IDCR, with other program leads in program for emerging infection, and we have shown that at the national level there is about seroprevalence level already by April to October had risen to 52%. In the slum, in Dhaka city, in the slum it was 74%, so the exposure must have been very high. In the non-slum, it was a little bit lower, but we also saw that COVID-19 antibody responses in high socioeconomic status, in high density areas, was higher than because of the nutritional status and the healthy nature of these people. We also showed that right now the antibody levels are very high. In our latest studies, we have seen even in rural Bangladesh about 80 to 90% people have seroconverted to COVID antibodies. So that means we have reached a high level of seroprevalence, but I won't say we have reached herd protection because that will come both with vaccination and natural exposure. So we've done many things. We have 4 vaccines that are being given of the 7 vaccines that have emergency use authorization in Bangladesh. And of those vaccines, we have looking at the AstraZeneca Covishield vaccine, the other 3 vaccines are Sinopharm vaccine, the 2 other vaccines are Moderna and Pfizer vaccine, and we're looking at the antibody responses and the longevity of antibody responses together with IDCR and with funding from USAID, Gates Foundation, and support from ICDDRB. And we've seen that after taking the first dose of COVID vaccine, 93% participants become seropositive. And by second dose, 100% participants become seropositive at 2 months after second dose. We have done a lot of studies, and we've seen that the vaccine antibody lasts even after 3 months or 6 months, as you can see in the last bar on the slide. So antibody levels go down, but don't go down drastically. They still remain. But we know that antibodies, IgG antibodies, do come down with memory B cell responses. These climb up again as soon as there is exposure. We're also looking at the genomic epidemiology of Sarskoftu at ICDDRB and in my sister organization at Aideshi, which I lead also. And we have involved with the COVID-19 genomics in projects, and we are continuing our efforts to follow the Wuhan type to the Alpha, Beta, Delta, and now the Omicron. And so we do this all with MinION sequencing and where possible with Illumina sequencing. And we have collaborated internationally with all countries, the Mass General Hospital, with University of Gothenburg, with Nick Thompson at Sanger Institute, and our collaboration has taken us very far with these vaccine studies and the genomic studies. So in conclusion, I would like to say I have dedicated my life to infectious disease research to achieve all the success over the last 3 decades, not only for myself, for my country and for ICDDRB. There have been many initiatives that we are working on that I'm interested in. I'm a very ambitious person on cholera, typhoid, E-tech, rotavirus, Shigella, H. pylori, hepatitis E vaccine, and infection, meningococcus, and rabies, which are key problems in Bangladesh. We have successfully executed our study findings at the policy level, both nationally and globally, especially with examples that I'm showing you for typhoid and cholera. However, COVID-19 has shaken not only our work, but also halted and delayed many regular activities. But we did not stop. And I'm thankful to my team, both national and international, and the collaborations. We continued our work in consulting with other stakeholders, donors, sponsors, and collaborators. And finally, I would like to spend the rest of my life on infectious disease research and finding solutions as much as I can, together with my team. And I thank everyone who has been so helpful in my effort in my life. First of all the donors that have always come forward in the universities, and the sponsors, and also the core support that ICDDRB gets. Without the ICDDRB format, we would not have been able to work. And I thank you all, and also the Ramon Magsaysay Foundation for the great honor that they've given me, that they've bestowed on me. Thank you very much.
Thank you very much, Dr. Qadri, for such an inspiring story for us, and for being instrumental in discovering vaccines that have saved millions of lives. This is really a prime example of bringing science to the marginal and the vulnerable population. And in your case, not just in Bangladesh, but in other countries facing the same issues. During this time of COVID-19, vaccine has become a central intervention for infection control. And I think the Q&A, in the Q&A, we'll have many questions with reference to vaccines at the age of the pandemic. At this point, we would like to introduce our panelists who will help us reflect and amplify on Dr. Qadri's work. And this will be the panel discussion one. I think we have two panelists here. Dr. Edsel Salvana, who is the director of the Institute of Molecular Biology and Biotechnology at the National Institute of Health from the University of the Philippines. Dr. Edsel received his medical degree from UP, and prior to continuing his training abroad. Dr. Salvanas received many awards locally and internationally for his work in public health, restoring vaccine confidence, and improving science communication to the public. Our second panelist is Dr. Romelay Camiling Alfonso. She's the co-convener of the Healthcare Professionals Alliance Against COVID-19, a board member of the Alliance for Improving Health Outcomes. That is the term now. We're now focused on health outcomes. If you want to have a health intervention, you always ask, what is the health outcome? Did it improve the health outcome? And she's also a technical specialist and a founding member of the Philippine Society for Public Health Physicians, and part of the steering committee of the Philippine Primary Health Care Studies. She received her master's degree in public health from the Institute of Tropical Medicine in Antwerp, Belgium, and her medical degree from the University of the Philippines. Our third panelist is Dr. Swaminathan, Chief Scientist of WHO, who will join us in the panel discussion too. Welcome, Dr. Swaminathan. So now may I give the floor to Dr. Edsel for your reaction. Dr. Edsel.
Thank you very much. It's an honor to be here. Good morning, good afternoon, and good evening, friends and colleagues, wherever you are in the world. Thank you very much, Dr. Quadri, for the incredibly inspirational lecture. Cholera and typhoid are very close to my heart as an infectious disease doctor and scientist working in a resource-limited setting. The research space for these neglected tropical diseases, as you know, is quite small, and funding has traditionally been limited as these are not priorities for rich countries. Science in general in developing countries is not very well funded, and I can only imagine that it must have been quite challenging to return home and compete for resources alongside the other priorities that your country's government has. I can only imagine the added challenges for you as a woman in our imperfect world, on top of already difficult conditions for scientists. It is quite gratifying to see how successful you have been at not only generating world-class research that is most relevant to your country, but also building institutions that will continue to push these important research agendas long after all our careers are done. As a scientist who likewise returned home, one of the first realizations I had was that the only people that can be relied upon to consistently look out for our country's research priorities are ourselves. Developed countries, no matter how altruistic, will at some point choose to put their resources in programs that are most advantageous to them. I am in awe at your ability to build research programs to tackle the basic scientific needs of your country and continuing to find the resources to sustain them. It is also apparent that you have been able to leverage the fruits of your research to attract international partners who are genuinely interested in the research agenda that is most relevant for developing country settings. Collaboration with foreign colleagues, while done with the best intentions, always carries a risk of straying away from the most impactful research that can make a real difference, as opposed to just another academic exercise. Your development of cholera and typhoid vaccines represents a truly relevant and life-saving endeavor. This is the true essence of science, not for its own sake, but as something that ultimately benefits humanity. I believe that despite all the challenges we face as scientists in developing countries, the limitations of resources forces us to focus on what is most relevant. While we all enjoy the intellectual stimulation of basic science as academics, we do not have the luxury of pursuing knowledge for knowledge's sake, knowing that the cost of reagents and equipment in our laboratories can feed entire villages. The diversion of resources for the pursuit of science must be done with an end goal to benefit the people when resources are scarce. And in this, you have succeeded spectacularly. And for that, you more than deserve this award. Your research advocacy has not only benefited your own country, but has spilled over to countries like mine. The cholera and typhoid vaccines you have developed are used globally and have saved millions of lives. Your development of a framework to use them efficiently in your country and abroad in partnership with the Global Alliance for Vaccines and Immunization, or Gavi, is a shining model of how research in developing countries can transform the world. I look forward to your endeavors that are now being brought to bear on COVID-19, and I cannot help but be optimistic that with Dr. Qadri on our side, no virus can beat us. Thank you very much.
Thank you, Dr. Edsel. We now have the reaction of Dr. Camiling Alfonso. Dr. Lay.
Thank you very much, Dr. Ernie, Prof. Ernie. And I'm very much honored to be here to finally be virtually face-to-face with Dr. Qadri. You make me so proud to be Asian and to be a woman. Thank you very much, Doctor, for the feat that you have accomplished in all the things that you've done. But I do not want to focus on your scientific technical work because your lecture gave me a glimpse of your character. And I would like to emphasize some of the things that I got from your lecture. And the first thing that I noted was that you had to change course. Your entire team had to change course. And you said your team was well set to study COVID when the need arose. And this is a quick transition. And often in low resource setting like ours, the equipment, infrastructure sets limits to us. and you were able to quickly navigate against that. But I believe that it's more difficult to help people transition in quick changes, having that quick pivot. We need to have a team with bright minds, but not only that, strong hands also, and resilient hearts. They matter more. And I commend your team for that. The team in Bangladesh and your international team, that was quite a feat. But what I saw here is that you nurtured that team that was willing to embrace the complexity of the circumstance, pivoting quickly. And the country and the world stood to benefit from this quick turn. And this organizational culture did not happen overnight. It was nurtured by your leadership. This is something that all leaders and research institutions should be able to strive for. The second one, Dr. Qadri, that strikes me most is your boldness. As a woman, you said, I am an ambitious person, and it strikes me a lot. Go, Dr. Qadri, because in a world wherein the WHO reports that only 20% of global health organizations have gender parity at the senior leadership level, you boldly saying this sends a message across the younger women that it is okay to be ambitious. We need to occupy space and we need to be ambitious. And this ambition allowed your research to not gather dust. It is this boldness and ambition that saw to it that your work will go past the hurdles of bureaucracy, get translated to national policy, and be implemented to reach the ones that need them the most, the communities. Not only that, to impact globally. That's a bonus. But I believe your heart really is helping your people. And this is such an incredible feat, having worked with talented experts, technical experts who are in maternal and child health trying to implement scale-up evidence in the Western Pacific region. And I would like to know more how you navigated this. Lastly, Dr. Qadri, I would like to point out that this ambition that you mentioned, you said it boldly, but it was not for yourself. It was for the people, really. And this ties up everything you've done. Your research interests are diseases of the poorest and of the poor, age-old problems that remain unsolved. Your body of work, Dr. Qadri, is by design equity-driven. And from the problems you choose to work on, the diseases, your route of institutionalizing them so that they reach the national level, and to the success in engaging the communities. This one did not escape me, Doctor, because you said both the rich and the poor accepted your interventions. And this is often a mistake, I believe, of many health managers trying to design interventions just for the poor, as if there's a temptation to have a double standard, that there is a service level quality that is for the rich, there is for the poor. Of course, that's not the intention, but the beauty of the design of your community engagement is that there is not just for the poor, but also engagement of the middle class. And that is something that's very challenging to do. And when I say, for example, you say equity, not just for the poor, you elevate that design, not just for equity, but solidarity. And as I transition to solidarity, your 3 years or 3 decades worth of success, Dr. Qadri, that design for engaging both the rich and the poor, and I see the contrast of the work that you poured out in finding vaccines, solutions towards age-old problems, and the quickness by which COVID vaccines came. And we see there like the solidarity of many countries coming in and helping out in developing that, and the speed by which you also contributed. COVID came and showed us what solidarity can do, the rich and the poor countries. And I am sure that by this award, putting attention to this work that you've done, you will be paving the way. You have already paved the way for support, recognition from the global north to the global south, to women scientists like you doing important work. Thank you so much, Dr. Qadri, for the inspiration and for the boldness that you have imparted for us. Thank you.
Thank you very
Congratulations.
much.
Yeah, thank you. Thank you. Fun girl. I'd like, maybe at this point, I'd like to ask Dr. Qadri to respond first to what Dr. Lay brought out. I think she brought out a lot of issues, the whole issue of women in science, ambition in the health sector, the whole issue of vulnerable population, the whole issue of inequities in health, and the whole issue of moving from the lab to the implementation to the policy that in fact really serves the underprivileged and the vulnerable population. Would you like to comment on Dr. Lay's reaction? Very impressive reaction.
Thank you so much. I mean, I don't know what to say. You summed it up so well. When I was giving my talk and planning my talk, I didn't expect it to be have this kind of an impact. Yes, when I said I'm ambitious, I think I am, because I always wanted to do something, and that's ambition, I think. Yeah, I would, as a woman, I would say first that I never considered myself as a woman. I always consider myself as a whole person, to be taken seriously. I think that was very important from the time I was in school, and then later on when I started working, did my research and started working, that was not to be felt as if I was not the same. So when I worked late at work and my male colleagues would say, why don't you go home? Your children will suffer. I made them see that I did my work properly. I took it very seriously. And also that my family would not suffer. Multitasking is my secret, actually. So, but if you want to think about women in science, that's a very, very important thing. We know with the STEM figures all over the world, women in science cannot persist. For some reason or another, they have given up in the past. But women like us are very, very, consider this point a lot about, that the females in our sphere of work should be given that extra inch so that they can carry on their work. And that little bit of an extra inch, that little bit of support takes them a long way. And being a woman, it has been, I see to it that I do that all the time. And I think now I've become a role model, and that's become very difficult for me not to do anything wrong. I have to be very careful because they look up to me, that if Appa can do it, they call me Appa. I'm the older sister in our culture. If Appa can do it, we can also do it. So I have to hold up to that model. And implementation science, like many lab scientists, I'm not a medical doctor, but a medical scientist. And so I would be sitting and listening from my lab and looking at the hospitals all the time. What was happening over there, we were working together with the ICTDRB hospital because our samples came from there. And I would feel very uncomfortable, especially from the 2005 onward. I thought that, I was not achieving anything in my life. If I could not help people who were suffering, were coming day in and day out with so much discomfort, so much illness to our hospitals. So I was doing high throughput research, but not being able to help anyone. And I thought my life and career would end if I didn't do something. And that's how I started moving into the implementation field. But nevertheless, my lab work is extremely important because that's where I get everything. That's where I get the knowledge on how to do the implementation science. So that is really 50-50, I would say. And so with that, I think I was very lucky to be in Bangladesh because people take you seriously. The health sector takes you seriously. And so I started working with them. It was not success at all in the beginning. Take cholera vaccine. When you talked about cholera vaccine, people in the health sector would say, why do you want a vaccine? I mean, you just wash hands and it'll be okay. And you have treatment for cholera. So many people don't die. At that time in Bangladesh, we did not even talk about cholera because it's a disease of the marginalized. And it was not, we did not talk about that Bangladesh has cholera. We just talked about acute watery diarrhea. And here it was this woman wanting to push forward a vaccine. But it happened. It happened gradually. We did a multi-sectorial approach. We have WASH, we have cholera vaccine, we have short-term, mid-term, long-term plans. So in that way, it has worked. But it has not been easy all the time. There have been many failures. I was younger those days, and I was not so well known in the fields and did not have so many prizes. Now people know me very well, so it's relatively easy to go and say that I'm so and so, and then they listen to me. But they I think understood that I meant business. We have a tier system of health where you go from one level to another until the Ministry of Health, but I realized that everybody wants to help the country. The health sector especially is very serious about taking away diseases. And that is one thing that was very common between what my team and I wanted to do, what ICDDRB wants to do, and what the government wants to do, and what globally what the WHO wants to do. And with a lot of support from the WHO always, we have been able to push forward with our work. And we've had so much support. If it wasn't for the WHO, we would not have been able to carry out the large campaigns where vaccines came into Bangladesh as soon as the Rohingya refugees, we don't call them refugees, the Myanmar displaced population came into our settings. And in 7 days, we had the vaccine altogether from the approval, starting from the request to the approval to the vaccines arriving in the country, and then the implementing. So I think it's important that we are serious in what we are doing. I think.
Excuse me, Dr. Quadri. Thank you very much for your response. What I'd like to maybe bring out is the point that Dr. Edsel brought out. I think he might want to ask you some questions, but I think what stood out from his reaction was that a country with limited resources can really develop world-class institutions and manpower to address infectious diseases that concern the more vulnerable population. Dr. Edsel, you want to ask Dr. Kadri a question or questions?
Oh, certainly. Yeah. Thank you very much. So, Dr. Kadri, I think as a scientist who came home just like you, what I really found interesting was that, no matter how altruistic or how good friends we are with our colleagues abroad, we're the only ones who really care about the problems that we have at home. It's more of an intellectual curiosity to them, but we have friends and family who are dying of cholera, of typhoid, of dengue, and all these things. So my question maybe would be, how did you kind of assert yourself to get to that level where you are able to get the resources and also get your international partners to go with what you think is really what is needed in your country? Because I think that that's really, really important for those of us who work in resource limited settings, and also kind of, make sure that the agenda is something that benefits our country.
Yeah, so thank you so much, Dr. Edsel. The question is something that I have to tell you about. When I started working on cholera, I was very young. And in fact, it was not such an accepted field because we had the oral saline, we had the IV fluids, and people were not really dying in Bangladesh with cholera. And it was not such an important area of work in the early 19, after the vaccine, oral cholera vaccine had been produced. But I think I was lucky because I was at the ICDDRB, which gives me the advantage of mixing the East with the West. Or not all institutions, I have to be frank, not all institutions in Bangladesh at that time had all the facilities. I was one of the I came from the University of Dhaka, and I moved to ICDDRB because I was always wanting to do research. And so with this, I had the opportunity to meet colleagues abroad who had some interest in cholera in the lab. And then we started working together, and those were the important things. I mean, USA, Gothenburg, Sweden, those were my main connections that led to the support I got in the lab, first of all. And the work was so serious, and because the work that was being carried out in the West and the North was not this, was like, in the labs, but the real touch was when we started working together. we started looking at real patients, not only at animal models and experimental models. We started looking at what the disease does to a patient, what it does to the contacts, to the household contacts. And so this has resulted in so much good work. And it has done two things. It has given the people in the labs outside Bangladesh a lot of encouragement, a lot of research materials, and a lot of skills. It has also given my team, our team in Bangladesh, the skills that they could only have got from if they were living abroad. But the mingling of the two has been very, very important. And I think without that collaboration, I could not have progressed. I have to be very truthful by myself, because you need so many fancy things. You don't have, even at ICDDRB, you don't have all the equipment, all the reagents. So did I answer your question?
Thank you very much.
Thank you very much,
Kadri. Dr. Lay and Dr. Edsel are incoming senior health leaders, no? And I think that all of us here will learn a lot from you, especially in your work in vaccines, really starting from the health burden, to the fact that it impacts policy. The work, in fact, contributes to a national cholera elimination program that has a budget for the next years, and that has a target for elimination by the year 2030. Very, very refreshing view. Thank you very much, Dr. Lay and Dr. Edsel, for this for the first panel discussion. Let's move now to the second panel discussion. And we'd like to welcome Dr. Sumiya Swaminathan. Dr. Swaminathan is a familiar family name in the Philippines. The father was formerly a past Ramon Magsaysay Awardee. He was a rice scientist at the International Research Institute, International Rice Research Institute. Dr. Swaminathan was appointed as the WHO first chief scientist in March of 2019, pediatrician in India, and a globally recognized researcher on TB and HIV. She brings with her 30 years of experience in clinical care and research, and has worked throughout her career to translate research into impactful programs. She received her academic training in India, the United Kingdom, and the United States of America, and has published more than 350 peer-reviewed publications and book chapters. Welcome, Dr. Swaminathan. And I now give the floor to Dr. Swaminathan for her reaction to the Dr. Qadri lecture. Dr. Swaminathan.
Thank you very much, Mr. Garilau. And congratulations, first of all, to Dr. Qadri for the lifetime of work that she has done for the Ramon Magsaysay Award, and for the wonderful lecture that you gave describing your life's work, your passion, your motivation, and your continuing commitment to infectious diseases research. Actually, I, as you were speaking, found a lot of parallels in my own career and life. Neighboring country, of course, India. Most of my life, I've worked at the Tuberculosis Research Center in Chennai, an institute of the Indian Council of Medical Research. And, there are 3 or 4 things that really stood out for me as lessons from my own life, but also from your career. The first is that it's not enough to be a very good individual doctor or a scientist. You need the institution, you need the ecosystem, you need the team. And I think both in your case and in my case, whatever we've been able to achieve has only been because of the institutional backup support we had, the teams we had, and the excellent human resources from top-class scientists in the lab all the way down to community health workers who actually get things done when they go into the slums and the communities. So it's really important for countries to think about investing in institutions and investing in people, in young people, and supporting and building their careers in science and research, because there are so many young people now who are motivated. And I think the pandemic has actually increased interest in science because of all the talk about vaccine development and all the other kinds of research on the virus. So this is a great opportunity for countries to support and mentor and build a cadre of young people who will be scientists, but who will also take up the other professions that you need. You need nursing staff, you need counselors, you need social workers, you need community health workers, you need lab technicians, you need physiotherapists, you need people for rehabilitation. Often these are forgotten, and the focus is on educating only doctors and nurses. So for me, the team is what has always been critical. And the more multidisciplinary the team, I think the more successful research is. And I think it's very well demonstrated as a lab scientist. You know, you could not have gone into these communities and done all of these large studies if you did not have the support of the clinical colleagues, of the doctors in the hospital, and of course, of the community workers. The second, lesson for me from my own career and what I hear from you is the involvement of communities and really engaging them and empowering them in what the ultimate end goal is. And I think cholera is a very good example. As you mentioned, it's so multi-sectoral in its approach that vaccine alone is not going to solve the problem. Community education alone is not going to solve the problem. And WASH, of course, will contribute in a very big way. But all of these need to be done together. And this is difficult because here we're talking about behavior change and culture change across many, many different sectors, and of course in the community itself. And let's again look at COVID and the kind of surprising reaction we've had from people around the world to something as simple as wearing a mask. People are protesting about wearing a mask. They consider it as opposed to their individual freedom. And of course, the same with vaccines. And so it brought home to me as a scientist that it's not good enough for us to develop an intervention to say that this is good at preventing this. And if you do this, then it's it, we've solved the problem. That doesn't work because we're dealing with human beings. And so behavior change is very complex, and you need social and behavioral scientists as part of the team, as part of setting the approach. And very often, I think in public health, we minimize or do not give the required importance to social and behavioral sciences as much as we do perhaps for the biomedical sciences. But I've seen that, whether it's the stigma of HIV and TB, or whether it's getting people to be compliant with long courses of treatment, or whether it's sorting out some of the social problems that these people who live in poverty have. And we're talking about diseases that affect the poor. Unless we also look at their social circumstances and try to solve some of those problems, we're not going to get the desired outcomes. So I found many times with my TB patients that I would give them lectures on what they should be doing. And then when I visited their homes and saw the circumstances in which they're living, I felt ashamed that I was trying to lecture them on things which were clearly impossible given the circumstances that they lived in, and without dealing with some of those issues. And with HIV, but also with TB, I learned a lot about what stigma in the community can actually have, the kind of impact it can have on families, sometimes driving them to despair and to suicide. So dealing with all of that, including the mental health aspects of diseases, is clearly something that one learns as one goes along. We started off naive, I did anyway, but learned in my career. And the third takeaway for me is that And the previous two panelists really brought out excellent points. I'm not repeating, but the issue of global collaboration and solidarity, particularly when it comes to developing products which I think are global public goods, things like vaccines which save lives and drugs which save lives really are public goods and must be treated as such. And again, there's been now global debates going on COVID vaccines, intellectual property, the TRIPS waiver, transfer of know-how and technology, and the WHO has tried to play its role by setting up our COVID technology access pool. We've set up an mRNA technology transfer hub in South Africa to train groups from around the world on mRNA technology, clearly one for the future that can perhaps help solve some of our other problems like dengue and cholera and TB. But there hasn't been enough cooperation from the private sector, from the people who developed the mRNA vaccines, even though a lot of public funds went into the development of these technologies. All around the world, governments invest in basic research, and 30 years of investment in mRNA technology has paid off now because we have the proof of principle. But if those investments had not happened over the last 30 years, if those scientists had not persisted in understanding the basics of mRNA, we wouldn't have those vaccines today. So basic science is important, investment in R&D is important, but ultimately when it comes to a product which can save lives, there needs to be a global, some sort of a agreement or understanding about how we value these products, how we use them, and how countries can cooperate so that these products are used to save people's lives, not just for profits. And of course, when we talk about a pandemic, it becomes absolutely critical. But I would argue that even for other public health problems, big ones that kill a lot of people around the world, the same principles should apply.
Thank you.
Congratulations again, and thank you. For giving
well,
this.
now we have the interaction for this panel. Let me maybe just focus on what Dr. Swaminathan mentioned, which is, I think, critical when you talk about involvement of communities, empowering communities, behavioral change, especially for the vulnerable population, which is we're really talking about primary health care. You know, how do you bring primary health care to the village such that they are identified, they have access to the health services, and in fact their health indicators improve as a result of that. Any reactions on that, Dr. Qadri? I mean, how is primary health care in Bangladesh, and what are the challenges challenges for the state in coming up with a good primary health care system? Because at the end of the day, when we talk about vulnerable population and marginalized population, you're talking primary health care. Dr. Qadri?
Yeah, so being a person of vaccines, I would like to interpret primary health care in Bangladesh as among the developing countries or lower middle income countries, whatever we call ourselves, our primary healthcare system is, I would say, quite good. I mean, there's a lot of room for improvement, but we have gone down to come from primary healthcare. We have the community clinics. We have all the vaccines that we are targeting, 11 to 12 vaccines for the children. And there are access to primary healthcare all over the country, not only in the cities, but in the divisions, different divisions, 8 divisions, down to the subdivisions and the Thana level. So there's a lot of effort in primary healthcare, but there has to be improvement. So I think Bangladesh would think about just health as it is in terms of even the COVID vaccine. We are going down to vaccination up to 12 years of age, school children, and we are also going to go down to children maybe 5 years of age. So that's that kind of a tempo. And also mother's health is also very important. And so there is effort, but you see, there's always the limitation of funds. We have 170 million people, a lot of young people in our population. And although the rate of children per couple is 2 to 3, it was 6 to 7 30 years ago, but thanks to efforts of many institutions, the government and NGOs, it has come down. So with that, we can see that there is a very big effort, but there's a lot of room for improvement.
Yes, yeah. Thank you. Dr. Swaminathan, would you want to ask Dr. Qadri a question for further amplification?
Maybe what I would, Dr. Qadri, you did mention about the fact that the patients in the hospital really moved you, to do more for the community and get into implementation science. How did you find, or how did you develop the relationship with the doctors and the clinical researchers in order to take forward your ideas into the community?
Dr. Swaminathan, you really picked up one of the things that I've done all my life. I'm a biochemist, not an MBBS doctor. But I knew that I would never be able to achieve what I want. I never thought of this kind of a success that I've had. Never thought about any award or medal or anything that I could get. But I was always taught that in order to do my work, I need to work with everyone around me. So I always have worked with the clinicians at ICDDRB and in the government sector in every way. I've worked with the universities in the science area in my field, but also with the clinicians, and as you said, down to the community health workers. So without that, you cannot succeed. So I knew what was happening. I used to pay a lot of attention what was happening in the hospitals. So I always had at least 40% clinicians in my study team. They're also there, 50, I would say, 50-50. And I've, you know how it is when the doctors and the non-doctors, there's differences. And I tried to first break that partition. I never had that partition in my heart, but I can see that the partition remains. So my first work in building the team has been to break that partition. And they work very smoothly together because you need everyone. The whole team means you need everyone. You need the epidemiologists, you need the clinicians, you need the scientists, the biochemists, the microbiology, genetists, and genomic specialists. But you also need your field. You need your people, your team, which for me has been very, very important, down to the slums where I work, looking into the homes, where my community health workers, my field workers, the people who look after the field workers have been very important. So the clinicians looking at the data every day, when the weekly report came for cholera to my computer, which it comes, when I talked to the clinicians, I knew what the problem was, the shifting of cholera from Inaba to Ogabad to the new 01390 group that really focused me on cholera. Remember when in the early 1990s, we had a new serogroup of cholera, nobody knew what it was. That was my breakthrough into cholera. I worked on Shigella before that. Because when I wanted to go into cholera, people would say there's not enough work on cholera, but work on Shigella, and there was not so much.
But the other thing that struck me, Dr. Qadri, was the fact that you brought out this point that data throws light where there is darkness. You know, people used to call it acute watery diarrhea. In many countries, people still like to call it acute watery diarrhea and not cholera. Nobody wants to acknowledge that you still have cholera, you know. But the fact that you do the surveillance and you actually show the policymakers that there is this burden of disease gets them to move, you know, to take action. So it's really, really important to collect data. And in many countries around the world, I think there are huge gaps in data, huge gaps in mortality statistics. So policymakers are very often blind to the kind of problems their communities are actually facing.
Yeah, actually, you're right. You're so right. Because AWD was all that I could make people talk about, acute watery diarrhea. And it's only in the last 2-3 years that we're talking about cholera from Bangladesh, talking about it first for vaccines for cholera for the FDMNs, and now in the host population. And now we are directly talking about cholera when other people talk about cholera. So isn't that a big thing? But I have to tell you that I couldn't have done it if I did not have all the funding agencies. When I'm thanking everyone, I just realized without these foundations, without people who trusted us, without money, you can't do anything. So, and that was also a very, very big support. I won't name them first, but then you can imagine without that, you could not move. But I think I've been very lucky, very, very lucky.
Thank you, Dr. Quadri. We still have a few minutes now. I'm just, maybe I can ask you this question because it's very relevant. Your work in cholera resulted into the National Cholera Control Program of Bangladesh, and that by 2030, you want that reduced by 90%. And you set up a 3.58 billion plan, and that you in fact had strategies, like strengthening surveillance, treatment, information campaign, and wages. You think that this is a feasible program, that by 2030, 90% will have been eliminated? And what would be the challenges for that? The reason why I raised that is because, in a sense, sometimes countries are hesitant to really put national targets. You can have national targets there, but you don't really fund the national targets. No? So at the end of the day, you're still lagging behind insofar as the initial targets are there. So what is your take on that? I mean, what does it take to really meet the target, or to meet the target maybe sometime in 2035 or whatever?
So, Mr. Ernesto, the whole thing is that it's the WHO Global Task Force for Cholera Control, of which I'm a member and have actively participated, is the End Cholera Roadmap, Ending Cholera Roadmap that we are following in Bangladesh, also in all the other countries. So using that framework, we've developed the National Cholera Control Plan. The Ending Cholera Roadmap has all these components, and we have brainstormed and looked at our population, looked at the data that we have from ICDDRB, from the IDCR, from our projects on the national cholera surveillance, and we have come up with this. And you can see that cholera vaccination, although is an important element for the short-term protection, we say like mid-term, but at least you can get the disease under control. And so that is an expensive, but the watch part is always very expensive. As Dr. Swaminathan pointed out, it's very important to change behavior. We have in our studies given hand washing pump, chlorine pump, hand washing basins, and liquid soap. And it disappeared even before the study ended. I mean, so it's so difficult for uptake as it has been for mass. So I think for us, engagement is important. We have a big battle ahead of us, and COVID has actually derailed us quite a bit.
Yeah, right.
Yeah, we couldn't give them the second dose of the vaccine in the campaign in Dhaka city. And so we are starting again, and I can tell you with very good news that we are going to ask for vaccines to Dhaka city for the phase 1 of our study. So I'm looking forward to that.
Thank you very much, Dr. Quadri. Thank you, Dr. Swaminathan, for your participation. And maybe now we can move on to the question and answer from our virtual audience. Our first question will come from a young Filipino doctor who is a daughter of a past Ramon Magsaysay Awardee, the former former mayor and secretary Jessie Robredo. She's Dr. Tricia Robredo. Dr. Tricia received her medical degree from the Philippines and has recently trained in the United States. In addition to that, she's also the daughter of the vice president. Dr. Tricia, would you like to field your question?
Yes, thank you, sir. A pleasant afternoon to Dr. Quadri, to Professor Ernesto Garilau, To the Ramon Magsaysay Awards Foundation and to everyone in attendance today. I am Trisha Robredo and I am a primary care physician from the Philippines. Before I proceed, I guess, with my reaction and my questions, I'd first like to congratulate Dr. Kodji for this enormous and well-deserved distinction. And I'd like to say that I'm very honored to virtually meet you and to be invited to this discussion this afternoon. So to be quite honest, laboratory work has never been my strongest point. So I have always had high regard for scientists and for professionals in the field, especially those who are able to communicate technical findings, translate them into digestible information, and recommend evidence-based and tangible solutions for better public health outcomes. So as mentioned by Professor Garilau, I am actually fairly new to the workforce. I only started practicing a little over a year ago. So since passing the medical boards in December 2020, I've been taking on duties at the emergency department in hospitals while taking part in a pandemic response initiative that caters to indigent and vulnerable communities. So the lecture was very, very interesting for me. This work arrangement has really exposed me to two very different types of patients. So I see those who can seek treatment at the first sign of distress and those without means to even pay for transport to the nearest clinic, more so afford healthcare. So, working under these circumstances and in healthcare in the time of COVID made me realize that our communities continue to experience many inequities and systemic inequalities, where those who have less suffer the most. So, poverty vis-a-vis poor health is a complex and costly problem to break out of, but I also realize that inaction will only perpetuate the vicious cycle across many generations. So, listening to your lecture today, it made me appreciate greatly all the hard and tedious work done behind the scenes to fight for those who are challenged to fight for themselves. I have utmost respect for scientists like you, Dr. Kodji, who immerse themselves in the field to develop tailor-fit solutions for communities to benefit from. I have encountered an aversion towards research in many of my circles, as it carries a reputation of being too academic and intimidating, with a tendency of being disconnected from realities on the ground. So this was a very timely reminder, especially for young doctors like myself, to go out of our bubbles, to go beyond the goal of contributing to intellectual conversations, and to really strive to align our work with what society needs most today. More than that, I really admire Dr. Kodji and her team's persistence in finding feasible and cost-effective solutions while still underscoring the value of intersectoral collaboration in program development and implementation. It's been quite challenging for the medical community to assert themselves and be heard for many reasons. We grapple with political, sociocultural, and religious considerations on a daily basis, and misinformation has just added another layer of complication to the problem. And while I commend my colleagues for being relentless and in pushing through adversity to get their points across and serve the greater population, it's really been a struggle to make further advancements, especially in the field of research and development with very limited resources. So I guess I'd really like to get your thoughts on several things. For one, on how we could go about these limitations and push for culturally appropriate innovation and health reforms in the face of competing public priorities and limited funding. Number two, I'd also like to ask how we could probably address non-COVID public health concerns that are just as pressing. But since we are in an ongoing pandemic, understandably, all hands are on deck in the COVID response. But I'd just like to get your thoughts on how we could probably still manage and address all the non-COVID concerns. Number three, how we could get people to listen to science again, and how we could probably make research more attractive for investment and prioritization. Not just the institutions and agencies, but also the young professionals like myself who are still trying to find their place in the field. I'm sorry, I think those were very loaded, but I would just like to really thank you for the opportunity to take part in this discussion. I'm really honored, and I really want to thank you for the inspiration to be, of better service to my community. So thank you, Dr. Kodji, and congratulations again.
Yeah, thank you, Dr. Trisha. Dr. Kodri, your response.
Thank you, Dr. Trisha. It's nice to see young people spending time listening to me. So about culturally acceptable, whenever we do a study, we want to have something implemented in the country. you need to gauge what the feeling is. So we did, before we embarked on these ambitious things that I'm talking about now on the National Cholera Control Plan, we had to show the world that it was actually feasible, culturally feasible, possible to use this kind of a vaccine. The vaccine that I'm talking about here, the cholera vaccine, the typhoid vaccines, are not vaccines that I formulated or my team formulated. It was available, it had been formulated, but then you need that extra inch, a very big yard, to take it down to see how it works. So we did feasibility studies. We looked at behavior in the feasibility studies. We gave vaccines. We also had knowledge, attitude, practice, these innovative interventions. We also had a lot of behavior-related aspects that we asked the participants if they took the vaccine or if they did not take the vaccine. From that, we learned a lot about how to go around. We realized that you can't take a vaccine and take it in cold chain everywhere because that makes it expensive and tedious. And we showed that take the vaccine, keep it out in the open, even then it remains protective, has preventive capacity. Things that we did and we published that made people aware of what we were doing. So culturally acceptable, we had to do big feasibility studies. We had to keep reading their minds. When we went to a home where in a single room, a small single room where toilets are shared, there are 5 people, entire family living in that room, 3 or 4 children, mother and father. So, it would not be very different for what you see in the Philippines, but it would be like, you have to think about them. As Professor Swaminathan said with the TB, you have to see it from their viewpoint, what they have. If you ask them to wash their hands and drink clean water, it's very difficult when they don't even have money to buy all the food that they want. And they don't even have the water to cook their food. And you ask them to have clean water to drink and clean water to wash their vegetable. That's too much. So I think those were important, and limited resources. We are all living in countries, most of us, with limited resources. And we have to constantly tell our public health officials how this strategy, this kind of intervention is better or more important than any other thing that they're doing. Or comparatively, we have to show again by proof that yes, this would, if you have cholera vaccine or other interventions, the multi-sectorial plan, you will have less patients coming to the hospitals. You would have less cholera patients, less typhoid patients seeking help. You would have less people. One person sick with cholera costs $33 to the family in a country like ours. We calculated 5 years ago. So you understand the health intervention, how important it is important to calculate. So I think limited resources, you have to have the calculation, the studies to show that this intervention, the health impact of the intervention is important to show. And about people listening to science, it's very difficult. We scientists don't know how to talk to non-scientists. My problem too. When they asked me, when Victor and Susan asked me to say something that would be understood by everyone, quite difficult. So I had to take away all my graphs and tables that were difficult, and I tried to bring it down. But it's true that we need to work with people who know how to translate our science into a language that makes it an easily communicable on cholera, typhoid, COVID, everything. And so there are lots of efforts being done in this field, and we have some in our plan. There are strategies for accomplishing this, but it's a very important thing. And did you ask me something else that I didn't? How people listen to science? Science communication is very, very important, and we don't have enough of that in our own in Bangladesh, in our own society. We have to increase that.
Thank you very much,
Thank you.
Dr. Kadri.
Thank you, Dr. Kadri. Thank you.
Thank you so much, Tisha.
All right, we now move to the question and answer, but I think before that, there is a photo opportunity.
Yes, sir.
You want to give instructions?
Yes, sir. So before we continue to the Q&A, let's have some photo ops with the panelists. So please turn on your cameras. All right. So give us your best smiles. We are taking a screenshot in 3, 2, 1. All right. Can we have another one? Another one, please, in 3, 2, 1. All right. So returning the Zoom platform to you, Mr. Garilau.
Okay. Okay, so now we'll have the question and answer for the audience. The early bird gets the worm. So we had four people who wanted to ask questions from the chat box, and let me just get their names. One is former Secretary of Health, Manolet Dairit. The second is our trustee, Joey Quisha. The third is a correspondent from ABS-CBN. And the fourth one, whose name I don't have, is a Bangladeshi student. Maybe you can give me the name of the Bangladeshi student. Or maybe why don't we start off first with the Bangladeshi student?
Prof. Ernie, the Bangladeshi student is Amira Jalal. She's a student from Bangladesh. Her question for Dr. Kadri is, Dr. Kadri, what inspired you to become a scientist? You are a brilliant scientist as well as a great homemaker. How do you manage to do so many things all together? I think that's a good start for our Q&A this afternoon.
Yes, first, I have always I've been a born researcher. That has always been the thing that I wanted to do in my life, and so I became a researcher. But I think when you live in a country like Bangladesh, you have challenges always. But it's also another thing that I've noticed is when you're living in a country like Bangladesh, you get more support for your work as a woman. I am asked this question, what are your challenges? You're a woman scientist. But I would say because I live in Bangladesh, I've been able to accomplish a lot because of the support that I get at home. I mean, for bringing up a family, for doing things. So I would say that my science career has been actually something that I always crave for, and I see that I have accomplished it. And I don't think I've accomplished it. I've still lots to do. Did I answer the question?
Yes. Is the lady there? Is she?
She's in the audience, Prof. Ernie. But in the panel right now, we have Secretary Dairit and our correspondent from ABS-CBN.
Okay, we'll call Secretary Dairit. Dr. Kadri, Secretary Dairit is an epidemiologist, and he was formerly Minister of Health under the administration of former Secretary Gloria Arroyo. Manolet, your question?
Dr. Dairit, you're on mute.
Mute.
Thank you very much, Ernie. And thank you very much for promoting me from the audience to the panelists. Maybe just to greet Dr. Kadri, because I know of many colleagues from ICDDRB. I actually did some cholera research before. It was published in the Journal of Diarrhea Diseases of Bangladesh. I did a cholera investigation in a institution of mentally retarded persons. But anyway, my question has to do with the pandemic. And we've been trying to learn lessons from the different countries. We've looked at Taiwan, we've looked at Singapore, South Korea, but we've never heard about lessons from Bangladesh. And therefore, I thought this might be an opportunity to ask you, what did you think about your national response to the pandemic? And what lessons could we derive from them? Thank you.
For the COVID pandemic, our response—
Yes, the COVID pandemic.
Yeah, so the COVID pandemic, the response was very, very careful. We started off from the 8th of March, when the first cases were reported. I think very soon. And there was, the whole show was like, close everything down. But the country has to think about economics. We have people who earn on a daily basis. I mean, they work and get their pays on a daily basis. If you shut down everything, how do you have to worry also about the welfare of the people. So I think fortunately the head of the institution is a woman, and she thinks with a heart and a head. So there was a lot of controversy. So she did not, there was a national sort of extended holiday when we were supposed to not move around, but we did have limited people on the roads. But this was carried out very carefully and in a very planned manner. So first, this happened. There was a lot of effort given for PCR testing. And we had only 4 or 5 labs that had the facility. It has gone down to 1,000 labs now. The government has worked hard with the sponsors and donors and with its own. There were supplies for testing that came in very soon in March. And that was, remarkable. So we had RT-PCR testing. Labs were set up with many with VSL2 facilities. Anybody who had a lab, myself, I have 2 labs that I supported with as much as possible to the COVID pandemic. Then there was the vaccine. The vaccine effort was extremely important. The government also was very eager to know about the antibody levels. So we worked with our very sister institution in the government, the IDCR under the DG Health, and to look at what the seroprevalence of antibodies was. So there was a lot of interest, and there was everyday COVID reporting on the number of times on the television by high up in the government, in the health sector, telling us about the number of deaths, number of cases, and not to get worried, to wear masks all the time, to be careful, hand washing, personal hygiene. So I think Bangladesh took a very strong effort. Also, then the vaccine started arriving. And so from 2021, we started having vaccines. From February, I got my first dose, then I got the second dose, and I've got my booster also. So I would think that the efforts we've done, our country has made, is extremely high, very good, because our deaths are low. We are going through all the alpha, beta, delta, omega. Yesterday, our death was only 12. It is just single and double figures every day. I think our seroprevalence level has been high because of the way the government maneuvered it. We were not so close. We have, our hospitals have struggled hard, but it wasn't like that many people were dying without oxygen. There were many interventions. There were national committees set up that were advising the government. I was in several committees. So they were taking help from everyone, from all sectors. So I think being Bangladesh with so many other infectious disease problems and non-communicable disease problems, a lot of effort was given on COVID. Somehow some of the other things suffered, but now we are back on track with all the other things. Also, they're getting back on track. So I will say hands up to our country for going on with this.
Thank you, Dr. Qadri. Victor, who's next?
Prof. Ernie, we have a correspondent from ABS-CBN News. ABS-CBN is one of the biggest broadcasting network here in the Philippines. We have Jasmine Romero, I think, in the panel.
Hello, good afternoon. Congratulations, Dr. Qadri. My question to you is this. Doctors have expressed frustration with the Philippine government's seemingly lack of support for vaccine studies until the pandemic, where the importance of its studies suddenly was highlighted but came too late. What advice can you give the medical community to pursue their objectives despite minimal to zero support from the government? Where can they begin? What expectations should they have? And how do they keep their endurance in the pursuit of medical breakthroughs that will ultimately benefit their community?
So vaccine advices, can you repeat the question again? I just...
What advice can you give the medical community to pursue their objectives despite minimal to zero support from the government? Where can they begin? What expectations should they have? And how do they keep their endurance in pursuit of medical breakthroughs that will ultimately benefit their community?
So can I tell you?
Wait, if I'm the zero or minimal support from the community is from is the question from the correspondent. I'm not sure whether that came from Dr. Salda, Dr. Edsel.
So you mean vaccine advices? You are telling me about less support from the government or from the community?
Well, from the government, Dr.
Oh, the government. So yeah. So the way I have worked all my life is we have to. Okay, so what I would say that my advice would be try again. If you fail, try again. That's how I do it. Yeah. So what is happening is that the government, the health policymakers have so many problems, so many things they have to worry about, and then they have to worry about how it is reflected in the press. That is also a worry. But so it's not always that I'm successful or people are successful, but you have to keep on trying, because vaccine studies, supposing COVID-19 vaccine studies have been difficult, because here we don't have enough vaccines, then we want to do a lot of science. And so, but then you have to do things that will be of benefit to the policymakers, like the seroprevalence studies, the vaccine antibodies that are being raised, the neutralization antibodies. The government wants to know these, but they don't have neither the funds nor the setup to do all this. So if you can help them with these efforts and not wanting too much back in return, I think the government policymakers do agree, do support you, but you must know about the limit of support you can get. You need their permission to do the work. I think all governments in the world, they cannot fund you for many things. They do not have, countries like us don't have so much fund. They are already so much involved with COVID. Just take the example of COVID. They're so involved with the resources that need to be given to COVID. So if you come in with extra things that you want to do, you must have your good reasons for doing it. And also reasons why this will improve the situation in Bangladesh. You must, or in Philippines, or in any other place. Not that we are always successful. It is a difficult job.
Dr. Quadri, maybe I'd like to follow up that question. I mean, you're a health professional in Bangladesh, mostly working with the non-government sector. No? I'm sure that in your 30 years, you would have had frustrations with the government policies or implementation of health in Bangladesh. How did you handle your frustrations? I mean,
there have been many frustrations. Today I'm sitting over here with the Magsaysay Award, with so many people saying so many nice things. This is not what it's always like. I'm not always smiling. So there's a frustration, like for people to understand what you're trying to do. In the beginning, always. There's always a lot of frustration. And people don't want to, when you go to big meetings and people say that this is not a disease that they want to talk about. There are other problems that are more important. We are having that all the time with other vaccines, even with the cholera vaccine, I have had many frustrations. But it took me how many years? I've been working for 30 years. It took me, still taking me. There's a lot to do. I haven't finished my job. I have to go to the cholera end game and the typhoid end game. We have, I don't know how much we will succeed, but you have, I think in developing countries, also in developed countries, and there is the problem for you to make the policymakers understand, because they have a big bowl of things that they have to do. And then you come here with a little thing that you want to do. And to them, that problem may not be that big. So you have to convince them with data, with real hard data, with the way you can be articulate. You take your team members with you, government, non-government, experts, scientific experts, national and international, to put in your word. And you also have funding, quite a lot fund. You have to have your funding to support your work, because governments in our countries don't have the funds to allow you to do everything.
Thank you, Dr. Kadri.
Prof.
Victor?
Ernie, Prof.
Who's
Ernie, in
next?
the interest of time, we will be combining some of the questions since there are lots of questions from our Q&A tab in our chat box. We have a question from John Michael Delfin and from Agui from the Philippines. Their questions are, Dr. Kadri, how did you gain the trust of the people in acquiring the vaccine at the time that there's no access to relevant information about the importance of vaccination? And on the other hand, Agui is asking, how do you deal with people who evade vaccinations, either for cholera, typhoid, or COVID? And how does this affect your efforts?
So, I mean, we know first of all, if I got your question right, the equity on distribution of vaccines is not what I would like to see in the world. If you talk about cholera and typhoid vaccines, these are diseases of countries that it's not like COVID. COVID is something that's happening everywhere at a global, it's a global pandemic. It's happening everywhere at the same time. So there's a demand is different. But if you talk about the other vaccines of the disease of the impoverished, those have a different impact. I mean, you have to force your ways through, you have to have funding mechanisms for countries to have these vaccines. And it's not always easy, but there have been many consortiums that have been set up for cholera, like the GTFCC, for typhoid. Those are very helpful. For COVID, we know there's no equity. We know that the COVAX facility was set up to create equity in the whole world, but we know that we did fail. There was failure, but even then with the COVAX facility, countries like ours are getting vaccine. So not at the rate which we wanted, but still, we have now in Bangladesh about 30 to 40% people vaccinated. We would like it to be 70% in a country of 170 million, but our access has been slow in the beginning, but it's gaining momentum. We have 7, 8 vaccines that are coming into Bangladesh. What do I say to people who don't believe in vaccines? I think there are two kinds of people. Some people who are not knowledgeable, don't know about vaccines, though they are the relatively simple ones. You can tell them about vaccines. In Bangladesh, we have a success of the expanded program for immunization, where children now live through their infancy, which was not like that before 20 years ago. We didn't have such an expanded program. All children get 11 vaccines by the time they're 9 months old. So that's the reason people believe in vaccines in our country. They still understand that there are infectious diseases and you can control them with vaccines and can prevent them. But I think for developed countries, that's a problem. People haven't seen real diseases and so they have hesitancy. So in Bangladesh, you can still reach out to people and tell them about the vaccine. They can ask you many questions, but those you can answer. Vaccine hesitancy is, I would say, not that big in Bangladesh, thank God. And people are usually wanting to take vaccines, but for COVID-19, many people have not seen disease. They haven't seen hospitalization. They haven't seen because severe disease. It has been, a big proportion of COVID exposure is like a flu-like exposure or asymptomatic. So they haven't seen the disease. So the question they ask, why should I take a vaccine? COVID is not for people like us, it's for the rich people or people who live in cities, but that's not true. We know everybody has to be vaccinated to keep the people safe. Everyone can go from a mild, moderate disease to severe disease. So I think it's the knowledge transfer, the continuous community engagement, that the talk shows on the television and the radio, people like us, people like all of us, talking to people, telling them if they have some problems in understanding what vaccines are, we have to tell them, give them stories. I hope this is enough.
Yes. Thank you, Dr. Kadri.
Prof.
The next question.
Professor Ernie, we have an interesting question from Maria Carmen Ablan Lagman. If I can rephrase her question, Dr. Kadri, how can we build more people like you? Or perhaps what she meant is, how can we encourage more people to go into science? And we at the Magsaysay Foundation actually want to push this agenda because we want to show people around the world that scientific breakthroughs can happen here in our part of the world and not just in the West.
Thank you for this question, because definitely I'm just ambitious and I want to do things. I'm a doer. So I want to give this, showing my characteristics and my personality. I have tried to encourage people around me. So I have ICDDRB, I have my own team here, which we call the MIVU team. And I talk to them, not only to the women, but also to the men, but what they should do. How should they pursue their work in the lab? Whether it's a young researcher or an older researcher, it's important for them to have a cause, to feel interested to come to work. It's not a job. You should not think of it as a job. Then I have a foundation that I have made with all the money that you all have given me from all the awards. And that foundation is to encourage even more people. Like if you have 50 more people being encouraged in science, I think I will have made some contribution. With what we have ICDDRB, we have some other institutes. So I have, for that reason, brought up this foundation, which is called the Aideshi Foundation, which is also trying to do capacity building to make more women and men interested, giving them labs, giving them the knowledge, giving them the interest to pursue science.
Maybe if I may add, I think one of the things that really stands out in this discussion in relation to the answer is really the whole issue of passion and competence, no? of Dr. Kadri. Passion, I think the passion stands out, passion for country and passion for the vulnerable population. I think that's the one that really stands out. And to be able to address the health burdens of the vulnerable population in our country, obviously you had to build institutions and you had to build a team, and you have to see to it that that competency is in fact there. No? I mean, you can do good, but you do good by doing well. No? And all this within a regime of limited resources. I think that's the one that really stands out here. That in a regime of limited resources, there is room for competence if there is passion, and if there is love of country, zeroing on the marginal population, and in so doing, just like Dr. Saldana was saying, and Dr. Swaminathan, it's really to build institutions. I mean, you can't do it alone. You have to build institutions and you have to build a team to be able to do that. And I think that's the takeaway lesson that we can get from Dr. Kadri. Victor?
Prof. Ernie, in the end, since it's already 4:30, I think we have room for one more question. This is from Maria Denise Seriote. Given that, Dr. Kadri, our lecture topic for today is From the Lab to the People, Creating Impact on Science and Communities. Her question is, what are the challenges, or what is the biggest challenge you have encountered during the process of creating vaccines? And perhaps we can expand that question. What are the challenges as well that you've encountered in delivering the vaccines to the slum areas in Bangladesh and to the people most vulnerable?
So I think we have had many challenges. I'm always afraid when we do some big implementation. And so the story of the cholera vaccine is one. When we first started out in a feasibility study, I saw myself on the television saying that she's treating humans like guinea pigs. So it's never very, very simple. You forget, when you ask this question, I can tell you that it's never simple. But you have to find a way. You have to show them that why we need the vaccine. And now we have the vaccine being used in Bangladesh. We will have it to wipe out cholera to elimination levels. So I think there have been many challenges. We were afraid every day what was going to happen. So with the typhoid vaccine, the same. You're giving an injectable vaccine to children 9 months of age. You have to educate the parents. You have to talk to them. We give out pamphlets and explain to them what was happening. You're always afraid of the press. You're all afraid of policymakers who may take you down. So these are problems that we face every day, but we can overcome them. We change every day. We know how to do it. We improve ourselves. We are never 100%. I learn every day from every criticism that I get. I think I say that Allah gave me another chance to learn. I see that, I did need to do this. So I think it's a never-ending process.
Prof. Ernie, before we end the Q&A, we'd like to thank everyone for throwing in their questions. Dr. Kadri, there are lots of congratulatory messages as well in the chat box. We will make sure to download them all and send them to you via email, so at least you will know how inspired everyone is here during the webinar. Prof. Ernie?
Thank you so much.
Okay, yes. Thank you very much, Victor. Okay, I think you have the synthesis. Well, if I would just, I think this has been a very rich lecture, discussion, and interaction. No? What I'd just like to maybe point out here, health leaders like Dr. Quadri are finding solutions, and we need more multidisciplinary research in eliminating the threats and the typhoid and even now the COVID. No? The next slide, please. And bringing the vaccines to the world must be inclusive. One of the things I think that looking, as I said earlier, I think Dr. Quadri in fact has a template for us all. You know? It is looking at the burden, it is looking at the immunity, it is looking at the host and the pathogen interaction. I think if you're a health professional, or even if you are a health administrator, one of the things that is very, very clear is what is the science for? What is the science for? Science in the service of, and in the case of Dr. Kadri, it is science in the service of the marginalized population. Because when you listen to her, the vulnerable population, in fact, has the numbers in a country. And by and large, if you're taking a look at cholera, these are really people living in urban slums, refugees, etc., etc. And somehow, in public health, we make a preferential option to serve that sector. And to be able to serve that sector, you bring competence to the field. She did mention about the laboratory test, the surveillance, taking a look at disease, studying the disease, doing the surveillance, and the reaction of the virus to the different formulation leading to the development of the vaccine. And that, in fact, even there, you move from vaccines that are injected to oral vaccines, but finally to vaccines that are effective, easy to administer, and affordable. Because that's the one that you do to the population. But I think the top here is the fact that as scientists, in terms of studies, etc., etc., it influences policy or it ends up in policy. And I think Dr. Quadri was saying, here is the evidence, and therefore, if it is the evidence, then you now be able to say the policymaker can take the evidence, and really come up with a national policy to be able to address the disease that involves the vulnerable population. I think in the case of health sciences and health, at the end of the day, what is it that we are able to do that influences policy, that policy in fact is implemented so that the vulnerable population are the ones that gain the most out of the science that we have. So I think that's overall, I think, and as was said, you can't do it alone. You have to have a team. You have to have your building institutions, and you need to do really collaborative work with government, with other sectors to be able to address that. So Dr. Kadri, thank you very much. I think you're a role model for a lot of the young health professionals. Quite a role model, exhibiting what Ramon Magsaysay Foundation calls the greatness of spirit. So thank you very much. Susan?
Thank you.
Thank you. Thank you both so much. Now, before I close and say my thank yous, I'd like to make a little plug here, because Dr. Kadri said earlier, money is very important. I could never have done anything without money and with people supporting me. So I want to announce and invite everybody that is listening to us today and watching this, that the Ramon Magsaysay leadership team is actually coming up with a lecture series. And for February, we're going to talk about fundraising. That's all we're going to be talking about is fundraising and how to make money. So for many of you that are interested in fundraising, please make sure you reach out to any one of our board of trustees, anyone in the Magsaysay community, so that you can get your seat in this invitation-only event. Before I also say my closing remarks, I can see our chairman, Chair Gigi Montinola. Chair Gigi, I don't want to put you on the spot, but you might want to have some closing messages here as well for Dr. Kadri and the team. Go ahead.
I think everything's been said by everyone. It's a great webinar. What struck me is that you have a lady who really felt that she wanted to be a scientist. There's a target. The country and the lady and everybody else with them work towards it. She emphasizes the importance of being able to work on the cultural side, and I like what she said on how to answer people who don't want to have vaccines. So, and thanks to the panelists, excellent questions. Thanks to the people who asked questions, very probing questions, and good luck. This is the kind of thing that we like to do at the Ramon Magsaysay Award Foundation.
Thank you. Thank you, Chair Gigi. I also would like to thank, of course, our moderator, Mr. Ernie Garilau. Maraming salamat. Thank you so much. Dr. Sumiya Swaminathan, Dr. Edsel Salvana, Dr. Lay Camiling Alfonso, Dr. Trisha Robredo, the Board of Trustees of the Ramon Magsaysay Award Foundation. And I just wanted to do a special mention to Ambassador Joey Quisha, Mr. Ramon Del Rosario, Mr. Shell Habito, who are all with us. And also we have Magsaysay awardees, Dr. Ernesto Domingo and Angkana Ni Lapejit, who is also with us this afternoon. We would like to thank everybody who joined us from all across Asia via Zoom or through our Facebook and YouTube live stream. From what we can see, just from Zoom alone, we have over 200 people that have joined us, and this is not counting the other people that we have not yet accounted for via our live stream. But lastly, this webinar would not have been possible without the commitment and the passion of our 2021 Ramon Magsaysay Awardee, Dr. FIRDAUSI QADRI. With your greatness of spirit, solutions can create immeasurable impact in the lives of others. Thank you, Dr. QADRI, and to your executive assistant, Shizir Saldawin, and Tarif Islam Khan, the head of ICDDRB. Thank you. Thank you, everyone.
Thank you so much.
If you want to know more about Dr. QADRI, you may visit their website. Just type www.icddrb.org for more information. The webinar evaluation form will be posted in the chat box and live stream comment section after the event. Please note that the certificates will only be sent to participants who have answered the online evaluation form. To be updated with all our activities, we invite everyone to follow the Ramon Magsaysay Award on social media. You will find us on Facebook, Twitter, Instagram, LinkedIn, and YouTube. Thank you again for joining us. And we will be closing the Zoom room in 2 minutes. Thank you very much once again for joining us today.
Bye.
Bye. Thank you again, Dr. QADRI. Excellent.
Thank you. Thank you so much, all of you.